The first in a series of three. Today, we are privileged to have a very experienced panel. Let me introduce the panelists to you. Our key speaker is Professor Miriam Were. Professor Were is a qualified medical doctor from the University of Nairobi and also subsequently received both a master's and a doctoral degree in public health from the Johns Hopkins University. She has worked as a medical officer for the Ministry of Health in Kenya, a teacher in the Faculty of Medicine of the University of Nairobi. She has been a UNICEF Chief of Health and Nutrition, and then also a WHO country representative in Ethiopia. In addition, Professor Were has been a director in UNFPA for East, Central, and Anglophone West Africa, from which she retired in the year 2000. And following her retirement, she has held many key positions, including being chairman of Kenya National AIDS Control Council, chair of the AMREF International Board, a member of the board of the Health Workforce Alliance, and currently she's the Chancellor of Moi University here in Kenya. Professor Were's focus has been mainly on community health services, including research and services, with evidence-based advocacy on the need to establish, support, and maintain community health services as the most cost-effective way to provide accessible quality health services. She has contributed in demonstrating that communities' burden from preventable, communicable, and lifestyle diseases can be changed for the better in countries with successful community health workers. She has had many recognitions for her work, including UNICEF's Maurice Pett Award for innovative approaches to primary health care in 1978, Kenya's Elder of the Burning Spear for outstanding contribution to the nation in the year 2005, Queen Elizabeth II Gold Medal for Public Health in the Commonwealth in the year 2007, and she is the first recipient of the Hideo Noguchi Africa Prize for Medical Services by Japan in the year 2008. And she's a designated Kenya's Community Health Strategy Goodwill Ambassador, a title that she holds to date. Welcome, Professor Were.
Thank you. Thank you.
Our second panelist is Dr. Githinji Gitahi. Dr. Gitahi is the Group CEO for AMREF Health Africa. Dr. Gitahi joined AMREF Health Africa in June 1, 2015. Until his appointment at AMREF Health Africa, Dr. Gitahi was the Vice President and Regional Director for Africa for Smile Train International, where he successfully established partnerships for long-term sustainability with various African governments. Prior to that, he worked with the Nation Media Group, where he was the Managing Director for the Monitor Publications in Uganda, as well as a General Manager for Marketing and Circulation in East Africa. He has held progressive senior positions at GlaxoSmithKline, at Avenue Group, and the insurance industry. Dr. Gitahi has a bachelor's degree in medicine and surgery, a master's in business administration, majoring in marketing, and Dr. Gitahi is also the co-chair of the UHC 2030 Steering Committee, a global World Bank and World Health Organization initiative for universal health coverage. He's also a member of the Private Sector Advisory Board of the Africa CDC and of the World Health Organization. Well, yeah. Thank you, Dr. Gitahi, and welcome to the panel. We are also very privileged today to have Mr. Genichi Terasawa. Mr. Terasawa is going to make a statement at the end of the presentations by our two panelists. He is the director of Hideo
Noguchi at the Prize Office. Thank you.
Okay, thank you very much. We feel privileged to have you in this panel, and you'll be making a statement.
Thank you very much.
So, ladies and gentlemen, participating today, we have quite an interesting agenda, and after the speakers, you will have a chance to ask a number of questions. In fact, you don't have to wait until the session ends. We will take your questions on chat. Just chat and we will pick the questions because we will not have time for oral questions. So please remember, we are not going to have you talk, just chat and ask your questions. Now, before we start, I also want to appreciate the other people in the room. We have the AMREF Chief Programs Officer, Mete Kinoti. We have Dr. Nyagero, who already started us off. We have Donna, who is our Regional Advocacy Manager. And we have a very important person in the room representing the people we are talking about today, Margaret Kilonzo, who is a community health worker. And she's here also to answer any questions which may be asked and are relevant to her. So as we start off, I have 2 slides to start us off. The slides are being loaded. We are talking about community health workers, but in what perspective? We need to understand how the current healthcare system works so that you see how this fits in to the overall picture. Okay. Yeah, so the health system, as for those who may know about this, is made up of 6 building blocks, which WHO has come up with. And they are there in this diagram: leadership and governance as a block, healthcare financing, health workforce, medical products and technologies, information and research, and service delivery. And the health system intends to improve access and coverage and quality of and safety of services. And if in this framework, if we implemented everything, then we should have improved health and also responsive healthcare and financial risk protection and improved efficiency. But you may notice something here that I've highlighted in red. There is a glaring gap when it comes to communities. The health system seems, the framework we use in the world today seems to have left out community health workers. Communities are not part of the health system as we know it today. And that is something we are going to talk about today. Now, if you take the service delivery pillar of the building blocks of the health system as we conceptualize it, it's really a pyramid made up of the big referral health facilities at the apex, and then below it you have the referral regional health facilities in any country. Then you may have district hospitals. In countries like Kenya, you might have county and then district. You may have health centers and then dispensaries, and then what we are calling the community. Now, as you go up this pyramid, the system gets complex and accessibility becomes more difficult. And so if you want to reach more people, you cannot reach them through the referral hospital. You can reach greatest number of people at the community level of the health system. That is where access reaches most people. Now, the tragedy we have today is that we have concentrated in building this complex block, the complexity of the system, and providing healthcare, which is treating diseases rather than improving health. Because improving health is really through the community health system if it works. And so this has led to many issues that the panelists will be talking about. And so with that introduction, I want to introduce Professor Were to take over and talk about the community health worker agenda and how relevant it is for our health systems today. Professor Well.
Thank you very much, Professor Osul. I'm happy to make some comments on community health workers because I have been involved with NERI for nearly 50 years. Community health workers. I have worked in communities and seen traditional healers. Now, as you know, traditional healers can be quite dramatic. And that drama is part of the culture. There are people who prefer to have community, who have traditional birth attendants rather than modern maternity care because of the approaches, because of the things that go with that traditional birth attendings. And in many ways, the traditional lifestyles of our people don't always go hand in hand with modern healthcare. So it becomes a problem because now when our country is relying only on modern healthcare and ignoring completely the people, then a lot of people are left out. Because the meaning of health and disease in African cultures is not the same as modern medicine. In Africa, we have many who have a sick role. We understand the sick role and how people should treat you in a sick role. I know myself, when I used to use the health system, before I became a member of the health system team, I used to be so puzzled by the formal addressing of sick people in the health system, as if they are not looking after you nicely like the traditional healers do. They're not spoiling you. They're not looking at you sympathetically. And that is very important in our cultures. And so this makes the modern health system a little bit disconnected from the people. And a distance develops between the people and their expectations and what the health system offers. They may be offering the best medicine, but that's not how people see it. People see it as a problem. And so, because of this, the fact that the modern health system doesn't reach everybody, it has been recognized not only in Africa, but in other places as well. And there has emerged what is called the 3 delays model. The things that delay use of health services, especially with respect to maternity care or safe motherhood care. And in this 3 delays model, you have got delay in decision-making to seek healthcare. Should I seek healthcare or not? The delays in getting to a health facility. Many of our facilities are very far from the people. And especially if you are talking about a pregnant woman who wants to deliver, how does she get to the facility? And then the delays in getting appropriate care at the health facility. These are the 3 delays that are recognized. And when they are addressed, things improve. But things don't always completely improve, especially in the African setting, because there is a 4th delay, which we don't always pay attention to. And that delay, the 4th delay, is the social distance, the issue of social distance. Now, the social distance has contributed to communities mistrusting the health system. If you don't feel that the health system is relating to you, why should you trust it? When epidemics come up, like Ebola, people lack trust in the communities. And so when the ministries say, do this and do the other, the communities don't want to do it because they ignore it, because they don't trust the ministries. Social distance keeps many women away to deliver at home, even though this may risk their lives, because they don't feel part of this system. Children don't always receive appropriate care because, again, they don't feel part of this system. And the unfortunate part is that even if the ministries of health in Africa received all the money they want to build more facilities and build more palaces, what we call the disease palaces, they will not reach every African. So we must address the issue of social distance. We must address the issue because many people have been left behind. Many people are currently left behind. And yet, we know that without good health, we cannot have productivity. And without high productivity, we cannot have economic development and overall development. So it is very important that we now turn to how to get everybody touched. Unfortunately, we are in the era of the sustainable development goals. And goal number 3 on health talks specifically of universal health coverage, leaving no one behind. And leaving no one behind gives us an opportunity to address the issue of the social distance that we find in African health systems. And the best way we have found to address this social distance is to have through community engagement, through community health workers, because they provide a bridge between the people and the formal health system. But unfortunately, many current community health programs are not very efficient because we don't quite understand what they should be doing. We have different definitions. Many are recruited and even trained, but they drop out. We have as high a dropout rate as 70%. Those who stay in the system, the community health workers who stay in the system, try to find other jobs so that they can earn a living, because most of them are considered as volunteers. They are not paid anything. So they try to find something to pay them and only pay attention to health work when they have time allows. And if this is the case, then it means that the community health workers donate their time when it is possible, but you cannot meet goals, you cannot hold them accountable if you are not having them all the time. And because of this lack of remuneration, there is no accountability for the work of community health workers, most community health workers, and what they are expected to do. So work is not done, and the national goals are not met. So what must we have? We must establish strengthened community health worker programs. And what do they look like? The first one is that they must be defined properly. Community health workers must be defined properly. They must have in-depth understanding of communities. They must be selected by the community through a participatory approach. Not just the chief sitting in his office and saying, I want Miriam to be a community health worker. No, a participatory approach. They must undergo standardized and accredited training so that they're trained properly to provide certain services. They must be trained to provide a package of certain services to promote health, to prevent disease, and also to provide some first-line curative services. And above all, community health workers must be recognized and remunerated as part of the health workforce, not on the side, not an informal arrangement, not an under-the-table arrangement, but recognized formal health workers. So what does a student health, community health program consist of? It means that there is a strengthened community health work program. We should have selection of community health workers that involves the community with respect to age, gender, values, and people who are acceptable to the community. They must undergo accredited training so that they have competence in certain issues that they are going to be looked for. They must have a clear scope of work, and their supervision must be structured and functional. So that this is a professional, a health worker whose duties are clear to the person and to the system and to the people whom they are serving. Second, the community health worker must have a career progression clear to the community health worker and clear to the community and to the health system. Community health workers abandon their jobs when they realize that it's a dead end. You know, you are doing the same thing and you're not being paid, and you're doing the same thing and you're doing the same thing for 20 years, for 50 years, or how long will you do it? So they abandon the thing. Civil service entry It's not defined for community health workers currently, but it needs to be defined for a strengthened community health worker program. A strengthened community health worker program must have must have duties and payments and must be regularly paid, not just ad hoc, so that it is clear that the community health worker has these duties and these payments. And when we have strong community health worker programs, we know that it is a very important program in a country. The first point to be clear about is that community health programs do not cost more money to the government, they save money. Every successful community health work program, for $1, you get $10 worth of goods. So it is a way of saving money. Community health workers can fit into the civil service once they are trained, because they can fit into the civil servants like drivers, like office assistants, so that they are part of the normal civil service system. As to how much work the community health workers should do depends very much on the density of the population. And it can be decided upon country by country or area by area. We also know that in Africa and in other parts of the world, we have got nomadic populations and immigrant populations. This may require mobile community health workers. But these are adjustments that can be made without too much distortion on the program. So if we can have a strengthened community health worker that is trained, that is paid, that is regular, and that is held accountable, you will have certain outcomes which are very useful to the health system. They bridge the gap between communities and the formal health system. Community health workers improve the confidence of communities in health, in the formal health system. I remember in my early 70s when I used to go to health facilities, you find the family that is just next door to the facility doesn't use the facility at all. So I would ask them, why are you not using the facility? Oh, those people, they don't behave properly. So the community health worker program that is working properly will reduce this, will improve the confidence of the people in the system. The community health worker program that is working properly will support the formal health system workers to understand and respect appropriate community norms. I say appropriate because some community norms can be a little bit strange. I remember going to one community and finding that they use cow dung on the umbilical cord to stop bleeding. So I asked them why, and they say because we have seen that when we cut our legs when we are digging, if you put cow dung there, it stops bleeding. But you know what that happens in a newborn? If you put cow dung, you are just inoculating tetanus. So they die. And they say, oh, why are they dying? Now, that is a long story. But you can't always say all community norms are okay, but they must be observed. But what is good, like breastfeeding, for instance, is encouraged. And this combination of factors will reduce the social distance. And with reduced social distance, we shall have increased global health security. Because one of the problems we have right now is that what happens in a community, in one community, can become a dramatic problem for the whole globe. That is what we saw in Ebola. It was in a few countries, but we are all traveling up and down all over the globe. I understand there are something like 100,000 flights per day globally. So we can move a disease from here to there. So the more we can control the diseases locally, the better. And we in Africa believe that it must be through the community health worker program. Paid, respected, trained community health workers. So what should we do going forward? What we should do going forward is that one, NGOs, like AMREF and others, must take a stand to support a formalized, integrated, and remunerated community health worker program. We must encourage the establishment of strengthened community health worker programs. Number two, governments need to recognize the importance of having strong community health programs so that they can develop appropriate community health program policies, and that the community health program is implemented within the Public Service Commission. Not something on the side, not something under the table, but a Public Service Commission program. And thirdly, development partners need to partner with communities and with government by putting money in strengthened community health programs. When we have volunteers, we think we have something when we have nothing, and we can't possibly afford that. We must have strong community health programs that community health workers that are paid, remunerated, that are trained, and that are held accountable for their performance because they are well supervised and supported. Thank you very much.
Thank you, Professor. That is very insightful. And now we are going to have Dr. Githinji Gitahi take over. I just wanted to say Dr. Githinji has tested what it means to be a community health worker. He has gone to the community and done that work together with Margaret Kilonzo, who is here, and others. So he's talking from a point of experience in addition to the knowledge that he has. Dr. Gitahi, please welcome.
Wow, thank you very, very much. Professor is always very inspiring when she's talking about community health workers, because it is something she's worked on, researched on, and seen for very many years. So my experience and my ability to share on community health strategies is nowhere near what Professor Were can do. And therefore, for me to be asked to make reflections on Professor Were's presentation is an honor that I don't deserve, but I will give it a shot anyway. So thank you, Professor. We really appreciate it. Professor Were has talked about social distance, which is a concept which is very difficult to capture or to grasp if you haven't experienced the challenges of the health system in middle-income and low-income countries, especially where they are highly informal. The social distance that Professor Were has referred to is, to me, one of the biggest contributors to a medicalized health system. The reason the health systems in low-income countries and middle-income countries are highly medicalized is because the public health system, the community health system doesn't work, and therefore the health system is built to respond to medical treatment, surgical treatment, and such. It's actually built to respond to the failed prevention and promotive strategy. And until governments that are actually looking to establish universal health coverage consider the closing the social distance gap as their best investment for UHC, we are not going to go anywhere, because as I saw somebody asked, with the leaking tap, would you rather keep mopping or would you rather stop and close the tap? As long as we do not close the social distance, then we'll continue mopping the floor. And mopping the floor will never stop. And I think this is something also that I've seen in some of Professor Were's previous writings about the leaking tap, and the fact that for us to stop the leaking tap, we have to go up to the community and let the community take ownership of the things they're doing. So for me, this concept of social distance that Professor Were is introducing is really, really critical. So the question is then, why is it that governments haven't understood this social distance? Why is it, and they're the ones actually who really understand the people or should understand the people, and why hasn't there been an investment in closing the social distance? I think in my view, there are many errors that have happened over time, since the Alma Ata 1978 and even before. And even by the time the WHO was convening and structuring the building blocks of the health system, there were errors, there were systematic errors that occurred. One of those errors was to think that you could have a system that was supply side only. and ignore the demand side of the system. And therefore, what, in my view, was created as the building blocks of health system was actually the supply subsystem. The supply subsystem, which reflects the 6 building blocks that Professor Osu has referred to, is not a health system. It is it's a health subsystem. And for me, the other part of the system of health should be the demand side, the community. Because if you create a supply, you must complete that supply with linking the demand so that you have a complete looped health system. Because the two of them form subsystems, supply and demand. And then you must close that. And the way to close that is through establishing an investment path for the community health strategy, through the community health workers and everything else that Professor Vera has talked about in terms of linking them to the health system, training, regulation, supervision, ensuring that they are actually compensated so that they are part of the health system. So that for me is one of the biggest errors of the health system, that is a subsystem rather than a system. The next issue is what I would refer as the WHO norms. Now, the WHO norms of human resources for health, again, are based on a medicalized health system. They're based on a medicalized supply subsystem, where we say that actually our biggest investment is medicalized cadres, and therefore we miss out the fact that even as we do the ratios, the number of, or the type and skills mix of health workers needed in a low-income country that's highly informal are actually different from a highly formalized developed economy. And therefore, we must review the WHO norms for them to be reflective of a complete system that also looks at demand side and what the population services require. And therefore, even as we talk about ratios of workers, we must disaggregate them and say, in this kind of environment, this is the ratio of community health worker to population you need. This is the ratio of nurses to population you need, instead of looking at it from a medicalized point of view and say doctors, nurses, dentists, pharmacists. So that is the other error, in my view, that we need to correct. The other final error that we need to correct is to imagine that actually you need community health. You can only have community health workers when you are rich. You actually need to have community health workers because you're poor. So we must then refocus our resources. Because we are poor, we must invest in community health workers. Because our fiscal space is small, we must invest in community health workers. We must not invest in community health workers when we have extra money after we've invested in the bottom or the top-down kind of health system that was shown earlier by Professor Osu. So as long as we understand that the reason we need to invest in the community health strategy is because our fiscal space is poor, then we'll be moving forward to the place where we need to be. So these are my quick reflections on the excellent Professor Were presentation, but I'd also like to reflect on a few countries that have actually attempted this. We know we have a few countries that have looked at the community health strategy in terms of an area of investment, and one of those is Ethiopia. We know Ethiopia has invested in community health strategy, but the Ethiopia system has tended to kind of, take an upgrading approach and has a one-year training, and then has kind of still has the community health workers. But I think one of the areas that we might have to look at the Ethiopian model is as to whether the community health workers they train work in the areas where they're identified, or whether they're actually posted after the training. So because, of essence, the community health workers must work within the communities where they're identified, because the social distance is closed by understanding the social and cultural norms of the people and having a very high level of trust by being from that community. The next country that has attempted this is Rwanda. Rwanda has taken an approach where they have community health volunteers, not workers. There are 45,000 of them, and they receive an incentive, not a salary, through a cooperative system. So they're put in a cooperative system, and then the cooperative is given some money, and that money is supposed to be invested in kind of income-generating activities, which the community health volunteers then share. So again, not fully formalized, but it's a good approach because it kind of has a good supervisory mechanism. They are required to report, they are supervised, and they are regulated, and they have a way of linking to the health system. But the best that I've seen so far in Africa is Sierra Leone. That Sierra Leone has actually established over time what they call the National Community Health Strategy. And the most recent one, which was launched in 2016, which is the National Community Strategy 2016-2020, actually states that community health workers will be part of the formal health system, will be remunerated, and states that they'll be given $15 a month, and will be supervised and will be part of the health system. And that is now in effect. And in a country where the per capita income is $1,300 a year, when you compensate a community health worker $150 a year, it's okay. It's a place to start, as opposed to places where they are left to be purely, volunteers. So for me, I think in terms of reviewing examples, I would say that the best example that people can look at in terms of a strategy that is already policy, that's already been implemented by a government, is the Sierra Leone case study. So I think I'll send back to the moderator, and thank you very much, Prof.
Thank you very much, and very important reflections. Now I want to ask Mr. Genichi Terasawa,
Thank you.
to make a quick comment.
Yes. Yeah. Today, it's my great honor to attend this the webinar meeting hosted by AMREF Health Africa. My name is Genichi Terasawa, the director of Hideo Noguchi Africa Prize Office, the government of Japan. Professor Were is a laureate of the first Hideo Noguchi Africa Prize in 2008. So maybe you ask, what is the Hideo Noguchi Africa Prize? Okay, let me give you a short brief. In 2006, the government of Japan established the prize to improve public health in Africa and advance the global fight against infectious and other diseases prevailing in Africa. It does this by recognizing, honoring people and organizations laboring at the vanguard of this battle. The prize is an unprecedented prize focusing on activities to fight infectious or other diseases in Africa. It is expected to encourage people dedicating themselves to medical services and to set a better role model to younger followers of medical services. The prize also contributes to upgrading medical services needed in Africa. Now, I'd like to introduce the reason why the government of Japan awarded the prize to Professor Were. For 50 years, Professor has dedicated herself to improve the health and welfare of people in Africa. As chairperson of the National AIDS Control Council of Kenya, Professor put together a balanced strategy for tackling HIV/AIDS and successfully reduced HIV infection rates and AIDS fatality rates in Kenya. During her time as a board chairperson of AMREF, she tripled Kenya's national health budget and led the expansion of medical services to rural villages through a community-based approach to health services. Professor Were also manifested her outstanding leadership as a co-founder of the Uzima Foundation to encourage and promote positive behavior amongst youth. Under her leadership, drug addiction among Uzima youth participants has dramatically dropped, and sexual reproductive health has shown significant improvement. Professor has also persistently exercised her tireless efforts and selflessness in aid of those who are less fortunate and desperately in need of medical attention. During her various careers in many international organizations, such as UNICEF, WHO, UNFPA, Professor Were is now promoting Mother and Child Health Handbook in Kenya as a part of efforts to mitigate high mortality rates of mothers and children in Africa. Please understand, it is impossible to cover all her achievements in these short remarks. Finally, let me underscore our determination to commit the African development. Japan has repeatedly held large forums with African state leaders since 1993 in order to improve social economic conditions in Africa, mainly through grant aid and technical assistances. The forum was named as the Tokyo International Conference on African Development, or TICAD. The improvement of the public health and welfare consistently has been one of key agendas at TCAD from the viewpoint of human security. Now, Japan is planning to hold the 7th TCAD in Japan in August of the next year, 2019. Taking the opportunity of the conference, the award ceremony of the 3rd Hideo Noguchi African Prize will also be organized in the presence of African state leaders. We hope the prize will be a symbol to open a new chapter of the cooperation between Japan and African countries to promote the public health and welfare in Africa. Thank you very much.
Thank you. Thank you very much. Thank you very much. And now we want to revert to the comments by participants and questions. I see we have 88 gadgets which are on, and I think each gadget may have many people. So I believe we are dealing with quite a number of people participating in this webinar. There have been very many inspiring comments. Allow me to read just a few. I think everyone is appreciating very much the panelists and very happy with the insightful remarks from the three of you. I find a comment here very important. NGOs can coordinate the execution, but government leaders need to lead the charge from the front, not from the back. I think that's a very important comment from Tyrell, one of the participants. Another one from Patrick Kagurusi in Uganda. Thank you, Professor Were. Government should relax the laws, regulations that restrict the admission of community health workers into the national workforce. I think there is a policy issue because governments are not allowing these people to do their work. I will also, before we go to questions, make other comments, read other comments here. The communities should be mobilized to demand for the recognition of community health workers. And so I think someone is thinking about accountability and making communities speak out. And there are many other comments. Let me go to questions. Maybe I will read a few and the panelists can respond, and then we read others. There is one here. How does $1 save $10? In other words, what do you mean when you say community health work programs save money? I think that is very important, and Professor Were can respond to that. And for Dr. Githinji, there is a question on UHC. If I summarize it, it simply asks, if you take the Kenya example and the process of implementing UHC that they have put in place, where are they putting community health workers? Where are community health workers in that process? Yeah, please.
Well, you know, one of the highest costs of health, ministries of health is disease, diarrhea, measles, whooping cough, and these are all preventable diseases. So by putting money in prevention, you reduce the cost of the disease. By putting money in promotion, you reduce, I mean, if you look at the cost of vaccine, say of a vaccine of diarrhea, it costs less than 1/100th of the cost of treating diarrhea. If you put the cost of measles vaccine to treating measles, which you can, many times you don't even succeed because many children die. So you see, the matter of saving is because you have prevented the disease or you have promoted the health so that people don't get sick. So that if you don't get sick, you're productive and you don't have to spend, nobody's spending money on you because you're spending very little money because it's just to help you eat better, exercise more, and that way, and so on, and you wash your hands, you protect yourself and your family from disease because the cost of disease is the problem. And community health approach emphasizes prevention and promotion so that the cost of disease does not stay so high and therefore becomes cheaper to handle. And that's how you save money.
Okay.
Okay, thank you, Prof. I think the question on UHC and Kenya is an important one. Kenya started its journey, and one of the areas they have identified as key is to design the essential benefits package. Now, the essential benefits package, which has been designed by Kenya through the Ministry of Health, starts from the bottom, recognizing that there will be population services and individual services. Now, population services are promotive, preventive, and those will need to be delivered essentially by community health workers. And then there is a referral process of making sure the individual services are referred to the facilities. Now, the challenge I think we have in Kenya is the challenge of devolution. It's not a negative challenge, it's just a challenge that we have to address. Because the question of ownership of community health workers and where they're budgeted for is a question that is facing Kenya now. Is ideally based on the devolved health services, the community health workers should be employees of the county governments. But it is also a public good for the government to make sure that we invest in community health workers. So this is where the current tension is. But the national government has prioritized that they are going to have community health workers engaged and paid for under the universal health coverage agenda. But for us to do that and make sure it's sustainable beyond the current government, is that there will have to be legislative changes in Parliament that also affect the Public Service Commission to make sure that the community health workers are defined as a cadre, they have a scheme of service, and they can be employed, and their job description is clearly defined beyond the current government. And that is where now the challenges have to be addressed to make sure it is legislative.
Thank you. And there is a recurring question here asked by many people, but in different ways. How do community health workers differ from the other cadres? Someone is asking, why can't we deploy community health nurses to work in the community rather than community health workers? Someone is also asking, what are we going to do with public health officers if we are talking of community health workers? In other words, I think there is a difficulty here. We are asking for another cadre, and yet there are many other cadres who seem to be doing the same work. Professor Were, what is this? What is the difference? What is the value that the community health worker is adding that we don't seem to have right now? And for Dr. Gitahi, there is another interesting question, because we've talked about how the complexity of the health system induces success. And someone is saying, are we not going also to make community health complex? How can we make it simple so that it delivers? Because we could still end up making it complex and inaccessible. Yeah.
The difference, one of the differences that exist between other health workers and community health workers depend on a number of factors. The first one is that the community input in the community health worker selection and deployment is not in the others. You don't have to have a particular orientation to a particular community to be trained as a nurse or a public health officer. You just qualify on your paper because you performed well in examination and you are trained to do those things. But for the community health workers, the first consideration is that the community health worker is from that community, is selected by the community, is trusted by the community, and is understood by the community, and understands the community. That is one consideration. The second consideration is that in most training programs, say community nurses and public health officers, these are training programs that take 2 to 3 years in most countries. Now, those are long-term programs. Because they take so long, the salaries are also very high. Therefore, the idea that you can have nurses in every community becomes impractical. You cannot manage to train sufficient numbers. So even Ethiopia, which is a bit long in training, is only 1 year's training for health extension workers. But in many other countries like Rwanda and elsewhere, the training of community health workers is a short course. It is a short course not because it is cheap or not because it is low quality, but because it focuses on certain issues that can be done at the community level. Therefore, the fact that it is focused on the community and prepared specifically for the community, it is appropriate, while the others are not. And lastly, it is very costly to try and put a nurse in every community. If the governments are afraid to put community health workers in communities because they are costly, imagine putting public health officers and nurses at the community, in every community, not in only in some, in every community. And it becomes prohibitive to the extent that it cannot be done. So this is why we must focus on community health workers for the community level.
Good. And I actually think that the question that has been asked, the further question about complexity, refers very clearly to what Professor Were has answered. That the structure for community health workers recognizes that the health system has nurses and public health officers. It's not a replacement. It recognizes that those structures exist, but because they are highly trained and scarce, they then are utilized to supervise, not to do the work of community health workers. Actually, community health workers also releases the time for the nurses to do more of skilled work that they have been trained in, but not to do the work that actually the community health workers can do at short-term training. In the case I talked about in Sierra Leone, the total time for training community health workers is 24 days. That's exactly what Professor Were is saying. It's just a short term to understand a basic package of community-based disease on health programs, and then you assist the nurses. So don't bring the nurses now to do what can be done by lower cadre, because then actually what you're doing is creating inefficiency in a higher trained, skilled person. So to simplify, these same people who actually reach the facility level, which is the health center or the dispensary, are the people who supervise. So the community health workers are not creating a parallel health system. They are being attached to the existing health system at the facility, but to work with the community directly and to report back to the facility where the health system already exists, to refer back to the facility where it already exists. So they're not simplifying, they're not complicating, they're actually simplifying the health system and making sure that demand creation is paid attention to.
Thank you. And a very interesting comment here, someone quoting Professor Were from another event you had, that you said if it's not happening in the community, it's not happening.
Mm-hmm. Yes, I have found that, you know, we sit at the headquarters of the government and the counties and say, we are going to have this and we are going to have this, but it doesn't happen. Until it's happened in the community, I can say for the last 45 or 50 years, unless when it happens in the community, then it happens. If it doesn't happen in the community, it doesn't happen. Yeah. You still find the children with dirty hands, with unwashed faces. If it doesn't happen in the community, it doesn't happen.
Yeah, correct. And you know, maybe just to add to that, I had gone today to visit Margaret Kilonzo, who is a community health worker in Kibera, and we were talking to her house and I was asking her, so in this community, if a woman calls, has labor at night, what does she do? She says, they call us. It's the community health workers they call. Who else would they call in the facility? You know, the facility is so distant because of this social distance. They call someone they trust, and then that person then finds a way to get them to the nearest facility for care. So this is what we are talking about. The community health workers, you cannot get nurses to do this role. This role is for community health workers.
Yeah. Yes. And I think there is a lot about government and its role. Everywhere, everyone is saying government should take leadership. In fact, many people are saying in these comments that government is the obstacle because of lack of policy. And I don't know what you can say about this. Are our governments doing enough?
So, Professor, do you want to say something before I give my view?
I think the problem we have had, first of all, when I started doing work in communities, my biggest opponents were my professional colleagues. Somehow they felt threatened. But instead than saying that we are threatened, they would say, how can you let ignorant women and men work like health professionals? And at that time, at the time I was trained as a medical doctor, we had 10% coverage, which means 90% were looking after themselves. So I would ask them, 90% are already looking after themselves. So they are being looked after by these ignorant people, so-called ignorant. How come they are not all dead? How come they are not all dead if we are only 10% coverage? So it is a misunderstanding which comes from the health professionals. Fortunately, it has changed a lot. And because of this, the health professionals have influenced the government to undervalue the opinion of the people. And so they think that working with the people is a waste of time. So they need to pay attention, because if for no other reason, for financial reasons, that we cannot afford a doctor in every village, but we can afford a community health worker in every village with better health results, as has been shown in Rwanda and even in Kenya. Yeah. We have got evidence that with a community health worker, you have better results than if you put there Miriam as a medical doctor to work as a medical doctor. So I think it is a matter of the government leadership. And we pray and hope that Africa will have the right leadership in the sector as well. Because when they do, health improves fantastically. Fantastically.
Yeah, I think my comment is finally is that this is an issue, from what I've seen, of the presidency of the country. We have tended to make it an issue of investment and the Ministry of Health, but community health workers is a major policy decision that also requires great political will and requires to employ thousands of people. That will not happen because the Minister of Health talks to the Minister of Finance. It will happen because the president of a country made a decision to say that we are going to focus on the people. That's what we saw in Sierra Leone. That's what we've seen in Ethiopia. That's what we saw in Rwanda. It is not a technical problem. It is actually a leadership issue.
And that's really a great point to end. It's a leadership issue. So if our leaders decide that we will have health in Africa and not just healthcare, we will have it. It would be nice for Margaret to say hi to the people. If you have anything to say before we end.
Okay, thank you very much. I'm very happy to see that you are concerned about the community health workers and recognize the work we are doing. Thank you very much.
Thank you, Margaret.
Yeah, thank you.
Thank you. Thank you, everyone, for attending. And now I invite Dr. Nyagero to tell us about the next webinar in the series and when it will be.
Thank you, everyone. I think we appreciate that you have been with us. We are again inviting you to join us on 29th of October. Same time, and that time we shall be focusing on a webinar that is going to focus on enhancing governance and accountability at national, regional, and global level to achieve universal health coverage. Once again, thank you very much. Let's meet again on the 29th of October.
Thank you. Thank you very much.
Oh, I should sit next to you always.
I learn a lot from you through osmosis and diffusion.